Ready to take on 25 pediatrics PYQs from the past 5 years? You will have 5 seconds to answer each question, which will be followed by an explanation of the correct answer. Let us know in the comments how many you get correct. Let's dive straight into the first question.
Question 1. Which of the following is an absolute contraindication for breastfeeding? Here are the options. A. HIV positive mother. B. Galactosemia in infant. C. Hepatitis C in mother. D. Tuberculosis in mother. And the correct answer is option B. Galactosemia in infant. Here's the explanation.
Now, what is the problem in these individuals is they are not able to digest this galactose. Okay, cannot be digested in this galactosemia. So, galactose and its toxic metabolites will get accumulated in the body and you will get various manifestations. So, basically, any form of milk or lactose containing products are contraindicated in a confirmed case of galactosemia. So, this is one of the very few conditions in which even breast milk or breastfeeding is contraindicated. So, in a confirmed case of galactosemia, even breastfeeding is contraindicated.
Question 2. A 5-year-old child presented with a history of edema of the face which later progressed to generalized edema. Urine showed massive proteinuria and light microscopy was normal. Electron microscopy showed effacement of podocyte foot processes. What is the diagnosis? Here are the options. A. Focal segmental glomerulosclerosis. B. Minimal change disease. C. Membranous glomerulonephritis. D. Post-streptococcal glomerulonephritis. And the correct answer is option B. Minimal change disease. Here's the explanation.
We now move on to a very important topic in children, that is nephrotic syndrome. So, nephrotic syndrome is basically defined as nephrotic range proteinuria or massive proteinuria. So, nephrotic range or massive proteinuria such that the UPUC, remember we mentioned the urine protein is to urine creatinine ratio, that is greater than equal to 2. Okay, so massive proteinuria, and as a result of that massive proteinuria there is generalized edema, hypoalbuminemia. Okay, so hypoalbuminemia, and there is also associated hyperlipidemia, though it is not essential for the definition anymore, but it is usually associated. So, if all these things are present, then we diagnose the child as having nephrotic syndrome. We call it congenital nephrotic syndrome if it manifests at birth or within first 3 months of life. Okay, manifests at birth or within first 3 months of life. Right? Now, the etiology of nephrotic syndrome, there are some genes which are known to be responsible, like the NPHS1 gene, which codes for the nephrin protein and which contributes to the congenital nephrotic syndrome, especially of the Finnish variety. Okay, congenital nephrotic syndrome, the Finnish variety. Right? The NPHS2, so NPHS1, the first alphabet is N, so it is nephrin. NPHS2, 2 means the second alphabet. The second alphabet of NPHS2 is P, so it codes for podocin, you can remember, and this is responsible for focal segmental glomerulosclerosis, which usually manifests as steroid resistant nephrotic syndrome. Okay. Apart from that, there is also NPHS3 gene which codes for the PLC1 protein, PLCE1 protein, and this also manifests as steroid resistant nephrotic syndrome, and there is a WT1 gene which gives rise to diffuse mesangial sclerosis. Okay, diffuse mesangial sclerosis. Right? Now, there are some syndromes associated with congenital nephrotic syndrome, and congenital nephrotic syndrome in general has a very poor prognosis or outcome. So, the syndromes associated are the Dennis-Drash syndrome, where the WT1 gene is mutated. Frazier syndrome, again where the WT1 gene is involved, WT1 gene. There is a Pearson syndrome. Okay, so this is different from the Pearson-Marrow syndrome that is there where there is exocrine pancreatic deficiency. The spelling is different. This is Pierson. So this is the Pearson syndrome where the gene involved is the LAMP2 gene, right? Then you have a nail patella syndrome. So at least the names you should be familiar with, that congenital nephrotic syndrome is associated with these syndromes, okay? So then there is a nail patella syndrome, okay? So the nail patella syndrome is associated with the LMX1B gene, the nail patella syndrome. At least the names you should be familiar with is associated with the LMX1B gene. And there is a Galloway-Mowat syndrome, okay? Galloway-Mowat syndrome, the exact genetic cause is not delineated yet. So these are some of the syndromes associated with congenital nephrotic syndrome that we must be aware of, right? Now the most common cause of nephrotic syndrome in children, we'll put a 3-star here. This has been asked n number of times and we all know that is something known as minimal change disease. Now why this is called minimal change disease? Because so normally we don't do kidney biopsy in children with nephrotic syndrome, especially if they are responding well to treatment. But if you were to look at the kidney morphology in minimal change disease, in light microscopy you will find that there is no change. The kidneys appear, the glomerulus appear to be absolutely normal. While in electron microscopy examination you can find the flattening of foot plate of podocytes. So flattening of foot plate of podocytes can be found only on electron microscopy of podocytes. So that is why it is called a minimal change disease, because there is no change on light microscopy examination in kidney biopsy specimen in these children.
Question 3. According to the neonatal resuscitation protocol, below what heart rate are chest compressions initiated? Here are the options: A. 50, B. 60, C. 80, D. 100. And the correct answer is option B. 60. Here's the explanation.
So in neonatal resuscitation, during neonatal resuscitation at any time, if the heart rate is less than 60 per minute, that means the baby has severe bradycardia. So what will you do? Start chest compressions, okay? So if the heart rate is less than 60 per minute, you need to start chest compressions. Start chest compressions. What do you do with the positive pressure ventilation? Do you stop it? No. So continue positive pressure ventilation. In fact, coordinate it with positive pressure ventilation.
Question 4. What is the pattern of inheritance in neural tube defects? Here are the options: A. Autosomal dominant, B. X-linked dominant, C. Autosomal recessive, D. Multifactorial inheritance. And the correct answer is option D. Multifactorial inheritance. Here's the explanation.
So some disorders have multifactorial inheritance. Where it results from the combination of multiple genetic and environmental factors. Okay, it results from a combination of multiple genetic and environmental causes. Okay, and there are some chromosomal disorders. So there are some chromosomal disorders where the entire chromosome or a large segment of the chromosome is missing, or there is some abnormality in that. Okay, so chromosomal disorders are the disorders where the entire chromosome or their segments are missing, duplicated or altered. Okay, missing, duplicated or altered. Okay, so multifactorial inheritance, here I would like to mention a few examples like cleft palate, neural tube defects. Okay, cleft palate, neural tube defects,
Question 5. A 7-year-old female child is brought to the OPD with cramping abdominal pain. On examination, she is found to have rashes on the back of her legs, buttocks and the extensor surface of her forearms. Laboratory analysis reveals proteinuria and microscopic hematuria. What is the most likely diagnosis? Here are the options. A. Systemic lupus erythematosus. B. Henoch-Schönlein purpura. C. Post-streptococcal glomerulonephritis. D. Hemolytic uremic syndrome. And the correct answer is option B. Henoch-Schönlein purpura. Here's the explanation.
Purpura. So Henoch-Schönlein purpura is a small vessel vasculitis which is mainly seen in children. It has a diagnostic criteria. What is the diagnostic criteria? Let us see. So there is palpable purpura. Okay, in Henoch-Schönlein purpura there is palpable purpura with one or more of, okay, so with one or more of the following. So what all? So there can be diffuse abdominal pain, okay, diffuse abdominal pain, arthritis or arthralgia, okay, arthritis or arthralgia, right? Or there can be renal involvement in any form. So there can be acute kidney injury, or there can be, some proteinuria, hematuria and so on. So renal involvement can be there, okay, or any biopsy showing IgA deposition. So any biopsy showing IgA deposition. So it can be kidney biopsy, it can be skin biopsy. So IgA deposition in any biopsy. So that is the diagnostic criteria for Henoch-Schönlein.
Question 6. Vitamin K supplementation is given to neonates to prevent? Here are the options. A. Breast milk jaundice. B. Hemorrhagic disease of newborn. C. Keratomalacia. D. Scurvy. And the correct answer is option B. Hemorrhagic disease of newborn. Here's the explanation.
This hemorrhagic disease of newborn. This hemorrhagic disease of newborn is basically due to the deficiency of vitamin K. And that is why the new name for this disorder is vitamin K deficiency bleeding.
Question 7. A child who was fed only on rice water presents with a swollen belly and dull face. His appearance is of a fat, have low serum protein and low albumin. What is the probable diagnosis? Here are the options. A. Kwashiorkor. B. Marasmus. C. Indian childhood cirrhosis. D. Kawasaki disease. And the correct answer is option A. Kwashiorkor. Here's the explanation.
So one very important difference that we've already mentioned is the edema. Okay, edema. So in Kwashiorkor, edema is usually present, while in marasmus, edema is usually absent. Okay. What else? Appetite. If you look at the appetite of the child, whether the child has willingness to eat or not. Okay. So in Kwashiorkor, the appetite is usually very poor, okay, and the child does not want to eat anything at all. While in marasmus, the child has a voracious appetite, that means very good appetite. He wants to eat anything that is given to him, okay. So, the child has a voracious appetite in marasmus, okay. Now, what about some CNS changes or apathy, right? CNS involvement is a very important salient feature of Kwashiorkor, which is not seen in marasmus, okay. So CNS involvement is present in Kwashiorkor, and because of that the child has apathy. Apathy means he's uninterested in surroundings, okay. Whatever is going on in front of him, he's least interested. So the child has apathy and lethargy or listlessness, okay. The child is not interested in surroundings, okay. But what happens in marasmus? In marasmus, the child is active and is, interacting with other people and with the surroundings. So it is an active child, and there is no CNS involvement as such usually seen in marasmus, okay. What else? Hepatomegaly or liver enlargement. In kwashiorkor, you can get a fatty hepatomegaly because in kwashiorkor there is energy deficit as well as protein deficit also. Because of protein deficit, because of hypoalbuminemia, you are getting edema, and because of lack of protein, there will be lack of synthesis of lipoproteins as well, which help in excreting the fat from liver. Okay. Now, if that is not there, what will happen? Fat will accumulate in the liver and there can be fatty hepatomegaly in kwashiorkor. Okay. So, in kwashiorkor, you can get fatty liver. Fatty hepatomegaly can be present in kwashiorkor. So, fatty hepatomegaly can be present in kwashiorkor, but it is usually absent or not seen in marasmus. Another important difference is the skin and hair changes. Okay, skin and hair changes of malnutrition. Skin and hair changes of malnutrition are usually present in kwashiorkor. Okay, but they are usually absent in marasmus. Okay.
Question 8. In a child presenting with febrile seizures, which is the first-line drug used to control the seizures? Here are the options. A. Sodium valproate. B. Phenytoin. C. Midazolam. D. Phenobarbital. And the correct answer is option C. Midazolam. Here's the explanation.
So, if a febrile seizure is lasting for less than 5 minutes, usually no treatment is required. So, it was asked in one of the exams once that if a febrile seizure is lasting for how much duration, then you will do some treatment. Okay, then you will give some management or give some drug. So, a simple febrile seizure, if it is lasting for more than 5 minutes, then usually drugs are required. Okay. So, management. In cases where seizure lasts more than 5 minutes, then you have to abort the seizure. At home, you can abort the seizure using rectal diazepam. Or nowadays, buccal, you can use midazolam nasal sprays are available. So previously, you used to have to give the diazepam rectally. That was very inconvenient for the parents as well as the child. Now there are midazolam nasal sprays available, which you can easily use. So you can use buccal or nasal midazolam to abort the seizure. Okay. So rectal diazepam or buccal or nasal midazolam, and put the child in recovery position, so left lateral position, and make sure you do not give anything orally, no fluids and nothing, so that there is no risk of aspiration. So put the child in recovery position. So put the child in recovery position. So this is the home management. And if the child comes with ongoing seizure to hospital, we usually abort it using intravenous short-acting benzodiazepine like lorazepam or midazolam. Okay. So this is the home management. And if a child is brought to the hospital, then you give intravenous lorazepam or midazolam to abort it usually.
Question 9. The following image is the most common cause of stridor in children. Identify it. Here are the options. A. Laryngomalacia. B. Laryngeal papilloma. C. Chronic epiglottitis. D. Laryngocele. And the correct answer is option A. Laryngomalacia. Here's the explanation.
One of them is laryngomalacia. So this laryngomalacia is the most common cause of stridor in infants. Okay, most common cause of stridor or noisy breathing in infants. And this stridor exacerbates on crying or on feeding. So exacerbates on crying or feeding, okay, or when the child is agitated, but it decreases when the child is placed in the prone position, because due to gravity the airway is kept open. Okay, so decreases in prone positioning of the baby, okay, in prone position. The symptoms usually appear in the first 2 weeks of life. The symptoms usually appear in the first 2 weeks of life and may increase in severity up to 6 months. So symptoms usually appear in first 2 weeks of life and may increase in severity up to 6 months, and then it might resolve spontaneously. Okay, the diagnosis is confirmed by flexible laryngoscopy. So diagnosis is confirmed by the flexible laryngoscopy, where you get the omega shaped epiglottis. Okay, so this is what the omega shaped epiglottis of laryngomalacia looks like. Okay, omega shaped epiglottis. Usually no treatment is required and it resolves spontaneously, just supportive care.
Question 10. The first primary tooth to erupt is. Here are the options. A. Upper central incisor. B. Lower central incisor. C. Upper canine. D. Lower canine. And the correct answer is option B. Lower central incisor. Here's the explanation.
Normal dentition in children, we said there is a primary dentition and a secondary dentition. So the primary dentition or temporary teeth, or it is also known as milk teeth, while secondary dentition is also known as permanent teeth, right? So now this primary dentition or appearance of temporary teeth or milk teeth begins at, so it begins at around 6 months of age, okay, 6 to 7 months of age, while the secondary dentition or the eruption of permanent teeth begins at around 6 years of age. Okay, so it begins at around 6 years of age, right? The first tooth to erupt in a baby, so mind my words very carefully, the first tooth to erupt in a child is the lower central incisor. Okay, or if the question is the first milk tooth to erupt in a child, then also the answer remains the lower central incisor is usually the first one. Okay, so each of these are very important one-liner questions.
Question 11. A 10-year-old child is brought to the OPD with a history of repeated fractures for the past 2 years. On examination, there is the presence of blue sclera and dental abnormalities. There is a positive family history. Which of the following is the most likely diagnosis? Here are the options. A. Scurvy. B. Rickets. C. Osteogenesis imperfecta. D. Osteomalacia. And the correct answer is option C. Osteogenesis imperfecta. Here's the explanation.
So classically what you get is a triad of manifestations. So what is the triad that you get? So the triad is of blue sclera. So the sclera of the eye appears blue. Why? Because sclera is made up of mainly collagen and there is a collagen defect. So sclera is very thin. So you can see the bluish choroid layer from the sclera. So that is why the sclera of the eye appears blue. So if you get a picture of a child with blue sclera, think of osteogenesis imperfecta. So there is blue sclera. Then there are bony deformities due to recurrent fractures and malunion. So bony deformities due to recurrent fractures. Okay, and there is deafness. So that is the triad of osteogenesis imperfecta. Apart from that, you can get some other features like hyperextensible joints. Hyperextensible joints can be there. Okay, and dentinogerous imperfecta as we already mentioned. So dental manifestations, dental enamel hypoplasia is there. So translucent teeth known as dentinogerous imperfecta may be seen in some varieties. And of course you can get a family history because it has autosomal dominant inheritance. So you can get some degree of affection in the parents as well. So family history in parents or siblings or in the extended family is important. Okay.
Question 12. A child with IQ of 55 comes under. Here are the options. A. Mild mental retardation. B. Moderate mental retardation. C. Severe mental retardation. D. Profound mental retardation. And the correct answer is option A. Mild mental retardation. Here's the explanation.
Children or the individuals who have IQ less than 70, they are said to have intellectual disability, previously termed as mental retardation. Okay, intellectual disability, right? and they have a significant impairment in their daily functioning, and on the cognitive domain or social domain or both. Okay, so there's a significant impairment in their day-to-day activities because of this. Okay, and it is considered to be a handicap or a disability, intellectual disability. Okay, so there is a classification of intellectual disability based on the IQ level. So if the IQ, we call it mild ID, mild intellectual disability, if the IQ level is between 50 to 70. Okay, so there is a classification of intellectual disability. We call it mild ID when the IQ level is between 51 to 70. So remember, we said the definition of intellectual disability is when the IQ is less than 70. Okay, so mild ID 51 to 70, moderate ID 36 to 50 IQ. Okay, severe ID we call it if the IQ is between 21 to 35, and we call it profound ID. Okay, that means the most severe variety, profound ID, if the IQ is between 0 to 20. Right?
Question 13. A 10-year-old male child presents with a history of spontaneous excessive bruising and hematorosis. On investigation, he has a normal platelet count, prolonged PTT, and normal PT. What is the most diagnosis? Here are the options. A. Von Willebrand disease. B. Hemophilia A. C. Bernard-Solier syndrome. D. Glanzmann thrombasthenia. And the correct answer is option B. Hemophilia A. Here's the explanation.
These children or these individuals are going to present with bleeding manifestations will be there. Okay, bleeding manifestations will be there, especially after trivial trauma. Sometimes even spontaneous bleeding can be there. Intracranial hemorrhages can be there. But the most common thing that happens is hemarthrosis. Bleeding in the joints is quite common. So hemarthrosis is quite common, especially after a trauma. So that is why these individuals are advised to avoid contact sports. Hemarthrosis is most common in the ankle joint, followed by the knee joint. Okay, these joints are most prone to trauma. Okay, so hemarthrosis is possible, and because of multiple repeated episodes of hemarthrosis, there can be development of irreversible changes in the joints as well. Okay, now what do you get on investigation in hemophilia? So on investigation, you can get the APTT, activated plasma thromboplastin time, is going to be elevated, but PT is going to be normal. So elevated APTT, but normal PT, thrombin time, bleeding time. Okay, PT, BT is going to be normal, and even the platelet count is going to be normal in these individuals. Okay, normal platelet counts, right? But if you do a factor 8 level, it is obviously going to be low.
Question 14. Which of the following is true regarding X-linked hypophosphatemic rickets? Here are the options. A. FGF23 levels decreased. B. FEX gene is affected. C. It is the most common cause of rickets. D. Excretion of phosphorus is decreased. And the correct answer is option B. FEX gene is affected. Here's the explanation.
So what is the gene that is involved? That is often asked in MCQs. That is the PHEX gene, the FEX gene. The FEX gene is a phosphate regulatory gene. Phosphate regulatory gene with homology to endopeptidases on X chromosome. So with homology to endopeptidases on X chromosome. Okay. So this FEX gene normally is involved in the production of an endopeptidase that is responsible for the degradation of FGF20.
Question 15. A 6-year-old child presents to the OPD with nausea, vomiting, fatigue, with oliguria. On examination, swelling around the eyes and both ankles was noticed. Urine output measured was less than 0.5 milliliter per kilogram per hour for the last 8 hours, and serum creatinine was found to be 1.5 times the normal levels. The patient comes under which stage of ARCI by KDIGO criteria? Here are the options. A. Stage 1. B. Stage 2. C. Stage 3. D. Stage 4. And the correct answer is option A. Stage 1. Here's the explanation.
KDIGO staging of AKI. Okay. So KDIGO is the short form for an institution which has developed a lot of guidelines related to kidney diseases. So basically it is a group or a network of collaborators. Kidney disease improving global outcomes. KDIGO stands for. So you have both guidelines for adults as well as pediatrics available from KDIGO. So kidney disease improving global outcomes. So they are international guidelines. All right. So there is a stage which you can arrive at either based on serum creatinine level or based on urine output of the child. Okay, we call it stage 1 when there is increase in serum creatinine greater than equal to 0.3 by greater than equal to 0.3 milligram per dl from baseline, or the serum creatinine becomes 1.5 to 1.9 times of baseline. That means there is an increase in serum creatinine from 50% to 90%. Okay. So serum creatinine becomes 1.5 to 1.9 times the baseline, or the urine output is less than 0.5 ml per kg per hour for 6 to 12 hours. Okay. Then you call it stage 1 of acute kidney injury. What about stage 2? So in stage 2, the creatinine level is going to further increase. It becomes 2 to 2.9 times the baseline. Okay, that means the serum creatinine level is going to become double to less than 3 times of the baseline. And what about the urine output? The urine output is less than, again, 0.5 ml per kg per hour for greater than equal to 12 hours. Okay. And what about stage 3, the most severe stage of AKI? So in stage 3, the creatinine levels become greater than equal to 3 times of the baseline. Okay, greater than equal to 3 times baseline. Or the absolute value of serum creatinine is greater than equal to 4 milligram per dl. Or serum creatinine greater than equal to 4 milligram per dl. Or there is a requirement or indication of renal replacement therapy or dialysis. Okay. Indication of renal replacement therapy or dialysis, or the estimated GFR is less than 35 ml per minute per 1.73 meter square, or estimated GFR is less than 35 ml per minute per 1.73 meter square. Okay. And what about the urine output? The urine output in stage 3 is very, very less. So it is less than 0.3 ml per kg per hour for greater than equal to 24 hours. Or there is complete anuria. Anuria means no production of urine for greater than equal to 12 hours. Anuria for greater than equal to 12 hours. So that is the KDIGO staging of AKI. Very, very important. Has been asked in the recent FMGE exam. A direct question, a case scenario was given, and it was asked, what is the KDIGO staging of this child?
Question 16. Which of the following is an autosomal dominant disease? Here are the options. A. Von Willebrand disease. B. Wilson disease. C. Cystic fibrosis. D. Friedreich's ataxia. And the correct answer is option A. Von Willebrand disease. Here's the explanation.
some examples of autosomal dominant disorders we need to know. So some examples of autosomal dominant disorders. So it comes as one liner. So like achondroplasia. What is the mode of inheritance of achondroplasia? So it is autosomal dominant. So we need to know some important disorders with autosomal dominant inheritance. So some examples of autosomal dominant disorders that we need to remember are hereditary spherocytosis, hypercholesterolemia, Ehlers-Danlos syndrome, achondroplasia, very important example, von Willebrand disease,
Question 17. A 16-year-old girl presents with short height, primary amenorrhea, with widely spaced nipples. Her probable karyotype is? Here are the options. A. 45XO, B. 46XO, C. 47XXX, D. 46XY. And the correct answer is option A. Here's the explanation.
Aware of, that is Turner syndrome. What is the basic defect in Turner syndrome? So it is 45XO. So these individuals have a single copy of X chromosome and no Y chromosome. And because there is no Y chromosome, it is always seen in girls or females. Okay, Turner syndrome is always seen in females because Y chromosome is absent. Now this again is a controversial question. Most common congenital heart disease in individuals with Turner syndrome. Remember, the best answer is bicuspid aortic valve. Okay, bicuspid aortic valve. But if bicuspid aortic valve is not there in your options, then the next best answer is coarctation of aorta. Okay, coarctation of aorta. Right? Okay, now the important clinical features of Turner syndrome you can remember by a mnemonic, see a baby clown, right? So not to offend anyone, but just using it as a mnemonic. So with S you have short stature. So individuals with Turner syndrome are going to have short stature, right? Now apart from short stature, they also have short fourth metacarpal. If you look at their fourth knuckle, it will be slightly posteriorly placed. So short fourth metacarpal is usually seen. And these individuals can also have a sensory neural hearing loss. Sensory neural hearing loss. Okay. With A, these individuals have amenorrhea, and that amenorrhea is usually primary. That means these females never attain menarche at all. Okay, amenorrhea, which is primary. All right. Now with B, bar body is absent in these individuals. Bar body absent.
Question 18. Koplik spots are seen in? Here are the options. A. Mumps, B. Measles, C. Rubella, D. Varicella, and the correct answer is option B. Here's the explanation.
Now moving ahead, the clinical features of measles. So initially there is a prodromal phase where there is presence of fever, conjunctivitis and coryza. The child has a wet kind of a look. Okay, there is fever, conjunctivitis and coryza. Right? And there are something known as Koplik spots. These are reddish spots with a white center. So these are Koplik spots which are present on the inner side of the cheek, on the buccal mucosa. Okay, present on inner cheeks. but they can also be present on conjunctiva and vaginal mucosa, okay, on conjunctiva as well as vaginal mucosa, okay.
Question 19. A 7-year child comes with complaints of bedwetting. Treatment of choices. Here are the options. A. Bed alarm. B. Imipramine. C. Desmopressin spray. D. Fludrocortisone. And the correct answer is option A. Bed alarm. Here's the explanation.
The second line treatment is basically bed and alarm conditioning techniques, okay. So bed and alarm technique, or bell and alarm technique also some people say, okay. So what happens in this, a moisture sensing alarm is fitted in the underwear of the child. So what is done in this technique is a moisture sensing alarm is fitted in the underwear of the child, and as soon as the child begins to void at night, the that alarm will ring and the child will wake up, and then the child will go to the washroom and void, and slowly he will get conditioned so that he wakes up by himself or herself and goes to the washroom and voids, and nocturnal incontinence is avoided.
Question 20. Renal agenesis in a baby is associated with. Here are the options. A. Single umbilical vein. B. Single umbilical artery. C. Polyhydramnios. D. Maternal anemia. And the correct answer is option B. Single umbilical artery. Here's the explanation.
So now what about unilateral renal agenesis? So unilateral agenesis is absent kidney development. So one of the kidneys is not developed. Absent kidney development on one side. So as a result, the child has a single kidney, okay. So absent renal kidney development on one side. So it can be basically secondary to a defect of either the Wolffian duct, secondary to a defect of Wolffian duct, or the urethral bud or the metanephric blastema, or urethral bud or the metanephric blastema, right. And there is increased incidence in those babies who have single umbilical artery. So normally there are two umbilical arteries and one umbilical vein in the umbilical cord, but if a baby has single umbilical artery, there are increased risk of renal anomalies in that baby.
Question 21. A continuous murmur is heard in. Here are the options. A. Patent ductus arteriosus. B. Ventricular septal defect. C. Atrial septal defect. D. Tetralogy of Fallot. And the correct answer is option A. Patent ductus arteriosus. Here's the explanation.
Because the pressure gradient in aorta during systole, across this ductus arteriosus, systolic pressure of aorta is 80 to 120, while pulmonary artery it is only 25. So huge pressure gradient during systole. What about diastole? Pressure in aorta is 60 to 80 millimeters of mercury, while pressure in pulmonary artery is only 10. So huge pressure gradient during systole as well as diastole. So blood will flow across the ductus arteriosus with a gush during systole as well as during diastole. So the murmur that you will get in patent ductus arteriosus will be throughout systole, throughout diastole. So it is known as a continuous machinery murmur, because huge pressure gradient is there between the aorta and the pulmonary artery in systole as well as diastole. So you will have a continuous machinery murmur throughout systole, throughout diastole, drrrr. So a continuous murmur will be there, okay. So that is what is typically seen in patent ductus arteriosus.
Question 22. Menkes disease is due to defect in the metabolism of. Here are the options. A. Zinc. B. Copper. C. Selenium. D. Iron. And the correct answer is option B. Copper. Here's the explanation.
So Menkes disease is caused by mutation in the ATP7A gene. So remember, ATP7B gene is responsible for Wilson disease, but Menkes disease is caused by mutation in the ATP7A gene, which is also a gene encoding copper transporting ATPase, okay. So gene encoding copper transporting ATPase. Right. So there is also impaired copper metabolism in this disease, and you will get less copper levels in liver and brain, but copper levels are elevated in enterocytes and fibroblasts. So in this disorder, copper levels are found to be decreased in liver and brain, while increased in fibroblasts and enterocytes. Okay, fibroblasts and enterocytes. Right?
Question 23. A pellagra-like rash is seen in? Here are the options. A. Gaucher disease. B. Alkaptonuria. C. Hartnup disease. D. Phenylketonuria. And the correct answer is option C. Hartnup disease. Here's the explanation.
Now, how will they present? Most of the individuals remain asymptomatic. Most of the individuals remain asymptomatic, and those who become symptomatic may have, cutaneous photosensitivity and a pellagra-like rash involving the neck area. Remember Casal's necklace that we talked about in the micronutrient deficiency chapter. Okay. So there can be, in the individuals who present, there can be photosensitivity and there can be pellagra-like rash. Okay, pellagra-like rash.
Question 24. The earliest indication of sexual maturation in females. Here are the options. A. Maturation. B. Thelarche. C. Pubarche. D. Menarche. And the correct answer is option B. Thelarche. Here's the explanation.
Puberty in females. The sequence of changes is very, very important. The first sign of puberty in females, very important, is thelarche or development of breasts. Okay. So thelarche or breast development is the first sign of puberty in females, right? So very important, often asked direct question, what is the first sign of puberty in females? So it is thelarche or breast development. So it is followed by pubarche or development of pubic hairs, pubic and axillary hairs. Okay, right? Then comes the growth spurt or the peak increase in growth velocity. So the growth spurt or the peak increase in growth velocity. And finally comes menarche or the beginning of the menstrual periods.
Question 25. A 1-year-old male child presents to the hospital with a fever associated with neck stiffness. You are suspecting meningitis. Which of the following is the most common cause of meningitis in this age group? Here are the options. A. Klebsiella. B. Streptococcus pneumoniae. C. Staphylococcus aureus. D. Mycobacterium tuberculosis. And the correct answer is option B. Streptococcus pneumoniae. Here's the explanation.
Amongst the infants and children, the most common cause of acute bacterial meningitis is currently Streptococcus pneumoniae. Okay, Streptococcus pneumoniae, followed by Neisseria meningitidis and Haemophilus influenzae. So Neisseria meningitidis and Haemophilus influenzae. Right?
Next up is ENT. Join us tomorrow and check how prepared you are to tackle ENT PYQs. Like and subscribe if you learned something new today. See you tomorrow.